Thank you, and thanks to Julio for inviting us to present at this meeting. And also, I'm presenting, of course, on behalf of the whole of my colleagues in HPTN 071 POPART. So firstly, I'd like to acknowledge, of course, our sponsor, the NIAID, and our funders, PEPFAR, 3IE, with support from Bill and Melinda Gates Foundation and the many institutes within the NIH. So the HPTN 071 POPART trial is being done in Zambia and South Africa, Zambia on the left and South Africa on the right. And as you can see, we're across three main central community areas in Zambia and in the Western Cape in South Africa. And the setting of our study communities are that they are slightly different from some of the studies we've heard before. These are urban and peri-urban communities. The communities are large, varying between the size of about 50 to 150,000 people within the catchment that we're defining as a community. And that leads us to have a very large total study population within those communities, we think around about 1 million people. The prevalence within our communities is between 10 and 22%. And all the provision of treatment within our healthcare facilities is through Ministry of Health and Department of Health routine ART and MMC healthcare services with everything that goes along with that. And I think for this meeting, clearly everybody here is very committed to the 90-90-90 delivery. Our trial is trying to look at how we can do this and to what level of uptake we will get across those different outcome targets and what the impact is on incidence within the communities. So this is a summary slide of the design of our trial. It's a 3-arm community randomized study within 21 communities. So communities are all divided into 7 triplets, 12 in Zambia and 9 in South Africa. And the arms of our trials are Arm A, which is a community level full, what we call our combination POPART intervention, which includes right from the start, immediate treatment irrespective of CD4 count. Arm B was the community intervention package, which you can see below in the blue box, with the exception that in these communities, treatment was started according to current national and local guidelines. And Arm C communities received standard of care, with treatment initiated according to local guidelines. So our primary outcome for the main study, which we expect to get in a couple of years' time, is HIV incidence at 36 months. And to measure this, we are recruiting a completely separate cohort, we call the population cohort, who will have 4 annual visits where blood samples are drawn, questionnaires are asked, and we've randomly selected approximately 2,000 individuals per community. So in total, we will have study endpoint data on 42,000 people. So just to go a little bit more briefly into exactly the details of what our intervention package consists of, importantly here, we recruited entirely new cadres of healthcare providers, community HIV care providers, and you can see pictures of them here. In South Africa, they wear purple shirts, and in Zambia, they wear green or green chitenges. And these people are paid, and they work as door-to-door universal offering of testing to everybody within that household. They promote services for referral for anybody found HIV positive, including pregnant women for PMTCT services, HIV negative men for VMMC, and they screen and refer for TB, reproductive and sexual health, and STIs. And the reason there are all these arrows here is that the household intervention begins what we call arbitrarily at the beginning of each round, and then these individual CHIPS people are donated a zone within their community, and they work repeatedly within that zone for the entire year, going back to households to pick up people that they've missed, going back to households to check on what's happened to those individuals who they've referred to care. And we also have some tents in the clinics that sort of help direct people, but the actual provision of care once people get to the clinical services is purely whatever is delivered by the departments of health. So how have we done in terms of getting to the first 90? So our intervention actually began in 2014. So the round 1, we call it, of this intervention was completed earlier, May, June last year. We visited in total around about 160,000 households, which we think is close to 100% of those which are based on our pre-study census. Adults consenting to the intervention, so this is accepting that that CHIPS person can come into their household and talk to them about HIV and offer a test, was approximately 84% in Zambia and 95% in South Africa. And of those consenting to allow the person to come into their household, 78% of the total populations we've worked with in Zambia knew their HIV status, and 93% in South Africa after the end of round 1. So in total, what difference did we make to knowledge of HIV status after round 1? And here I've highlighted men and women separately, where women are, I think it's pinkish. But before we began our study, we think people who knew their HIV status on the first CHIPS visit to their household, approximately 18% of men and 26% of women knew their status. By the end of the round 1, 80% of men and 84% of women knew their HIV status. So we're now about to complete round 2, and data will be available again in a couple of months' time on uptake of repeat testing. By April this year, we'd reached about 77% of all our households within the zones, and we've almost finished, as I say. For round 2, about 220,000 adults have reconsented to the POPART intervention. That's around 80% of our entire communities. So how have we done getting to the second 90? So here I'm showing you a cascade flow of men in blue on the left and women on the right in red. And this is taken from our 4 Arm A communities in Zambia as representation to show you how it's gone. So for example, the 4,000 men who were identified as positive, of those nearly half were already on treatment at the first CHIPS visit. The remaining 2,000 were referred to care, and within 6 months of that CHIPS visit referral, 40% were initiated onto treatment, and by 12 months, that was 60%. And similarly, on the right-hand side, you can see for women, the percentages initiating treatment within 6 and 12 months were similar to the men. So if we look at our whole communities, by the end of round 1, and the total population of untreated known HIV positives, we have reduced those who were not on therapy by about nearly half. So our next target was to say, how long does it take from referral from a CHIPS intervention in the household to somebody to actually initiate treatment? And again, this is only in the Arm A communities in both Zambia and South Africa. And we set ourselves a rather optimistic target, which you can see in the blue spot on the left-hand side, which was we hoped we would be able to have people initiate treatment within 80% of people would have initiated treatment within 3 months. However, you can see from the graphs, which show circles for Zambian men and women in red and blue, and squares for men and women in red and blue in South Africa, that unfortunately we're still way below that by the end of round 1. So about half the people had initiated treatment after initial CHIPS visit by about 9 months after that first test from the CHIPS referral. But I'm pleased to show you a bit more recent data that has shown that these different colours show you different quarters. I'm not sure if the colours come out on that screen for you, but from round 1 and then subsequently data we have from round 2, we've seen a very significant improvement in time to initiating treatment. These show per quarter in Zambia, RNA communities, so you can see that by 50% of the people have initiated treatment by 3 months in Zambia in quarter 2 of 2015. And we saw a similar pattern in South Africa as well, although this was a little slower than in Zambia, where to get 50% of the population to initiate treatment from that first visit of the CHIPS took between 6 and 9 months. And then we had a look at how it varied by gender. So are we getting more women onto treatment by time compared to men? And you can see here the different lines for men in South Africa and Zambia and women in South Africa and Zambia. And they're really quite similar, with the exception of a slightly slower rate to initiate treatment in South African men. So in summary, the first 2 90s I've just presented to you, we looked at very good rates of HIV testing acceptance. And you can see here for men on the left and women on the right, we estimate that there's approximately 6,300 men living with HIV in these communities. 52% of them on that very first CHIPS visit knew their HIV status or were tested positive for HIV. And by the end of our round 1, we had 79% of men who knew their status and 87% of women. So this is after our first round. We were nearly approaching the first 90. And similarly, the same pattern exists for those known positives on treatment. So we've improved that amongst men and women to being approximately 73%. So finally, just to talk to you about how we responded in our design with the new antiretroviral recommendations from WHO at the end of last year. So we have amended our design to expedite immediate initiation of treatment across all arms of our study. And we did this in advance of the guidelines changing in country. So of course, as you can now see, the design of our study is now that Arm B becomes identical to Arm A. So finally, we've got to look at what more could we do. We have an adolescent ancillary study which is being led by one of our Zambian PIs, Dr. Kwame Shanubia, which is looking at uptake amongst adolescents and what interventions we can do working with adolescent community advisory boards to enhance uptake amongst young people in our communities. We are looking within our study arms in Zambia at community and non-facility based treatment delivery models to try and enhance sustained treatment, people on treatment. And we've had to look at working our alterations to the CHIPS teams, as I think mentioned in the French group, to look at capturing men who aren't necessarily in the household. So the CHIPS teams have been working weekends and evenings, and we're looking into exploring offer of self-testing amongst the households to those people who aren't present at the time of the CHIPS visit. So finally, we are roughly halfway through the study with planned completion this time in 2018. I've shown you data from the end of round 1 of our intervention, which is looking encouraging in terms of the first 2 90s of our UNAIDS targets. And we've achieved, even after 1 round, almost halving the proportion of known HIV-positive people not currently on treatment. In Zambia, routine viral load testing is not currently available, so we can't answer from our intervention data whether we've achieved the third 90, but we will have blood samples from our population cohort, and we're doing viral load testing on that, which is currently underway, to look at community viral load testing. And in particular, I'd like to thank you for your patience listening, but also to thank very much our study team and all the partners, our government agencies and our implementing partners, without which, of course, this would never happen. In particular, I'd like to thank the study PI, Professor Richard Hayes, and our country PIs, Helen Ailes and Nolda Bayers, and of course, all our communities that we've worked so hard with to make sure that they can help us deliver what we're hoping to do. Thank you very much.